OPA. We use OPA and NPA when a patient's breathing is obstructed, normally due to their tongue blocking their airway. The contraindications for using a NPA or an OPA are a high GCS, trismus, epistaxis, or skull fractures. In order to use an OPA, you start by measuring it from the corner of the mouth to the edge of the mandible. Yep, so this one here is the right size. You insert it upside down like this and rotate it around to scoop the tongue out of the way and put it flush against the mouth. If the person is unable to tolerate it, you can use an NPA instead. This is an NPA. First you apply the lube to the NPA. This helps prevent soft tissue damage. Insert it into the larger of the two nares, very gently sliding it down the nose, like so. The risks for using an NPA and OPA are gagging, vomiting, tissue damage, and a lack of tolerance. So this is an oxygen canister. You can identify an oxygen canister by the color of the canister. It will either be black at the bottom and white at the top, or white like this and have a label around it that identifies it as such. They come with a regulator, sorry, not an applicator, a regulator. The regulator is attached to the oxygen bottle via the prongs and screw. So what you do is you line the screws up and lock them in place on one side, and then tighten the T-screw on the opposite side. You don't want to over tighten it, just so it's nice and snug, like so. You then test the amount of oxygen present in the bottle by twisting the top knob into the open position, and then using this knob on the side to control the flow of oxygen, which if this bottle had any oxygen in it would make a hissing sound, and the dial indicator would indicate how much oxygen was in the bottle. It's important after you stop using oxygen that you turn the top off, but then you flush out any remaining O2 by twisting this valve again to allow the oxygen to flow through that's stored inside the regulator. When using a bag valve mask, you need to check for leaks. The correct flow rate should be 10 to 15 litres. So with the bag valve mask, attach the tubing to the oxygen canister like so, via the regulator. Turn the bottle on and test the flow rate. This should be, I'll test it at 10 litres as that's the minimum amount. If this bottle was on, this bag on the bag valve mask would inflate and I'd be able to check for leaks in that manner. I'm just going to lay this oxygen canister down so that it's slightly safer because it should be as close to the floor as possible. Now it's important that you have the oxygen flowing before you place it over the patient's mouth so they don't get a sudden rush of oxygen down their throat and into their lungs, which could cause damage. So you want to tilt the patient's head back and keep it in that position. I don't have an offsider with me, so I'm actually using this rolled up towel to secure the person's head. This ensures that the tongue doesn't fall back and block the esophagus. I'll then place this over the patient's mouth, ensuring a good seal, using 2 hands if necessary, like so, around the patient. I'm now watching the patient's chest for chest rise. I'm satisfied with that. It's also good to check the stomach to make sure that there's no gastric inflation. The risks for using this, well, I say risks, more like contraindications. The contraindication for using this would be pneumothorax. If you put oxygen on someone and their chest rise appears to be uneven, it's probably a pneumothorax and you should remove the oxygen. This is my OSCE video for the lateral suction unit. To test the lateral suction unit, you turn the dial knob, press the test button, squeeze the tube together to test the suction level. The battery is a little low on this, so if I was to use this in a clinical setting, I would actually change the battery, which you can do on the underneath side of the device. The other way of testing the level of suction is to use the water provided with it, which is also used to flush the unit out. Like so. In order to suction a patient effectively, especially using a hard catheter, is to rotate the patient's head laterally so that any excess bile can simply spill out of the mouth. Only insert a rigid catheter as far as you can visually ascertain into the mouth, like so. Begin suctioning before you insert the device. Insert the catheter and place your thumb over the end to create a circuit, sucking for a maximum of 10 seconds only on the way out of the patient's mouth, like this. Some of the complications of using a suction device like this is bradycardia, hypoxia, aspiration, soft tissue damage to the palate, and induced vomiting. This device should not be used in a moving vehicle unless you're using a soft catheter. In a catastrophic hemorrhage, you need to work fast. You need to expose the site of injury and apply a tourniquet, like this one here. This is a bright orange cat tourniquet, which are carried by St. John. So, tourniquet needs to be applied to a single bone limb above the site of injury. In this case, the site of injury is exactly here on the proximal radius and ulna. These should be applied 10 centimeters above the site of injury if possible, but like I said, it needs to be applied to a single bone limb. So we're just going to tighten this quickly. Onto here, you don't need to worry about tightening it that much. That is the job of this windlass here. So the windlass, we wind the windlass up. This applies more and more pressure. Keep doing so until the bleeding has stopped and the radial pulse has disappeared. You can tuck this into the D-ring and cover it with the strap to lock it in place. Using a pen, write the date and time that you used the tourniquet. If you apply a first tourniquet, tighten it significantly, and the bleeding doesn't stop, you are able to apply a second tourniquet just above the first. Assuming that the wound is in the same position and is not deep enough to require a tourniquet, the first thing that you would do is flush it out with some saline. Depending on the mechanism of injury, this will remove any dirt or debris that is still stuck in the wound and just help to clean it out and ensure a lack of infection. If it's deep but not bleeding profusely, you can use a bandage like this to pack the wound. This is a fairly shallow injury, however, so I'm going to use a gauze swab, just like this. You want to make the padding that you use as small as possible to apply the most amount of pressure. If the patient were conscious, I would be able to get them to hold this on for me while I bandage it. However, if this patient is unconscious, I will do so. The first layer doesn't necessarily have to be that tight. It just needs to be fitted on. This gauze is quite stretchy, so you can wrap it around. A way of applying further pressure is to twist it like so and continue to wrap it around. This actually applies a lot more pressure than you'd think it would. Continue to wrap it around until you're satisfied that the bleeding has stopped. You can use multiple bandages if needed. For the purposes of this exercise, I'm quite happy with that. There's no blood spotting thrown through. I can cut this bandage with some scissors, twist it around, and tuck it in to secure it, like so. In order to analyze whether the patient has a fracture or not, I'm going to use the plastis mnemonic, which is analyzing pain, loss of function, unnatural movement, swelling, deformity of the limb, irregularity, shortening in specific cases, crepitus if I have a stethoscope and am able to listen, and shock. So I would definitely say that you have a fracture to your distal tib fib. Alright, so it's going to be quite painful to splint it. So what we're going to do is we're going to give you some pain relief first, some paracetamol and some methoxyflurane. If I could get you to just check the dates and stuff on those for me. Alright, so paracetamol is a slow-acting drug. So we'll give you that first, and then we'll give you the methoxyflurane, which you can just breathe in as much as you want. Now, before I do that, I've got to ask you some questions. Cool? Yeah. Have you had Panadol within the last 4 hours? No? Do you have any like kidney problems or renal impairment? No? Do you have a family history, or do you personally have malignant hypoxia? No? And have you had methoxyflurane in the last 7 days?
No.
Or paracetamol in the last 4 hours?
No.
Cool, we can give you all the fun drugs then.
Cool, so this is 5 milligrams of paracetamol and it expires 2018.
Okay, cool.
This
I'll
is
just give you 2 of these.
methoxyflurane, expires 2020, and that should be sweet to go.
Awesome, you swallowed those? Alright, so I'll get you to suck in on this whistle as much as you want, okay?
Okay.
Awesome. Alright, so I'll get you to give me a hand just to
sure.
pull in. Alright, so what we're going to do is we're going to wrap this in a towel so it's nice and soft for your leg, okay? Alright, ready, steady, lift. Alright, cool, yep. Back down, you're doing a good job. Take some nice, deep, slow breaths for me on that. Yep. How's your pain if you were going to give it a rating? Ready, steady, lift.
3.
A 3? That's really good. Okay, so when splinting, it's good to make sure that the foot is really nice and secure at the end. The idea of splinting is to stop movement, which will restrict any damage. Alright, I'm going to put this bandage over and then I'll say ready, steady, lift, and I'll get you to lift again. Alright, ready, steady, lift. Yep. Okay, cool. How is that feeling? Is it too tight or pretty good?
It's good.
It's good? Awesome. Yep. Awesome. So what you do is wrap this around as much as you need to and cut the end off and tuck it in. And then I'm just going to put the second bandage on at the top to make it really secure. Alright, and then we'll take you to hospital straight away, I promise. Okay. Alright. And if you can, yep. Awesome. Best offside arm. Okay. Is that feeling nice and tight? Yeah, okay, I'll tuck that in there. Alright, and I'm just going to check again before we move you to make sure I haven't accidentally cut your circulation off, okay, hon? Alright, so, yep. Cap refill is the same as before. Color and temp is unchanged. Excellent, we'll take you to hospital. Now, my patient here is unconscious, so consent is implied. However, I am going to talk through what I'm doing just in case they can hear me or they become conscious during the procedure. I wouldn't want them to panic. I've got an offsider here to help me because it requires 2 people to correctly place a C-collar on, one to stabilize the patient's head and neck, and the other one to actually conduct the procedure. Using a combination of the Canadian C-spine rule and the Nexus system, which stands for neurological deficiency, the presence or suspected presence of ethanol, an extreme distracting injury, if the patients are unable to give a history of how the accident occurred, and spinal tenderness. So these 2 concepts, plus my own clinical judgment, I've concluded that this patient does in fact need a C-collar. So I'll just get you to get a grip around their head, and we're going to lift them up and put a towel underneath. Okay, so we're just going to place this towel underneath your head, so you're not lying on the ground anymore. Ready, set, lift. There you go, so just like that. Yep. Just in case they have any tenderness or bruising on the back of their neck, it's a good idea to provide them some comfort while you're doing this. Alright, I'm just going to measure to see what size I need on this. So measuring on the side of the neck, that is approximately 5 of my fingers, which lining up with the bottom of the collar. That's about right. Okay, so I'm just going to put this collar on you to keep your neck nice and steady before we take you to the hospital. Alright, ready, set, lift again. Ready, set, lift. Yep, down. And fit that around and secure it with the elastic strap, like so. Philips AED and monitor. So before I turn the machine on, I'm just going to check that the test loads are attached. That will save me some time later. So this connection is good. You'd find this test load and its spare in the right pocket. This is the AED puck. This is connected as well and can be found in the same pocket. Alright, I'm just going to go ahead and turn this on. It will probably make an alarm noise because I don't currently have the leads connected, which means it will think that I'm in asystole. So I'm going to turn it to the monitor position. and let that start up. Once it starts up, I'm going to run a test on the machine to make sure it's in working order. Excellent. So we'll go menu. There's the alarm. Go to other. Start operational check. And acknowledge that we're leaving normal mode to run an operational check. Perfect. So I need to turn the therapy knob, this green knob here, to 150 joules, which is a standard adult dose for a shock. It will do a general systems test, followed by a therapy knob test. Then it will require me to press the charge and shock button to test that the machine is working fully. Verify test load is attached, which I did earlier. Press the charge button and the shock button.
Shock delivered.
Yes, I heard shock delivered, confirming that the audio test works. Alright, so while this is running, because it takes a little while, I'm just going to talk you through the rest of the machine. So like I said earlier, the 3 leads are located on this side here. I've added some pads on the end because I'm going to test them on myself later. You can also find the SpO2 monitor here and the CTO2. Located in the pocket on the right side, in addition to the test load and the AED puck, spare defibrillation packs. And sometimes you'll find a razor in here, otherwise it's normally stored in this back compartment. The other thing contained in this back compartment, which presses against the batteries, are the 12 leads connection, the GTN spray, some aspirin, and the pediatric size blood pressure cuff, in addition to spare pads for the 3 leads. You can also find spare printing paper in the back here, which I'll show you how to change in a moment at the front. The other thing that I didn't mention that's in this pocket is the blood pressure cuff, like so. So coming back around to the front of the machine, the test is still going. This is the printer here. You would have seen it printing some paper out earlier. It's a little bit fiddly to change the paper. You move the knob and open it up. As you can see, there's a fresh roll of paper in here, so I don't need to change that at the moment. And that slots back in there and clips up shut. The other thing is the MVP is just located, the switch for the MVP is located down here at the front, which is used to activate this. Alright, so the operational check is passed satisfactorily, and it's currently printing out the results. It's a good idea to print these out because you can then date and time them and attach them with the machine. That way the next person who uses it is aware of when the machine was last serviced. Now I'm just going to stop the printing and exit the operational check. Cool. So now that I've run through the check of this, I'm actually going to just do a quick test on myself. This button located here enables you to cycle through the leads available. You can change the volume in this menu here by pressing menu, going to volume. You can change the alarms, the voice, and the QRS. So just change the QRS to off. Perfect. You can go into the menu and have a look at the display waves as well. Wave 1, pads. You can scroll through and select them from there as well. And you can change the size that you're viewing it at. So I'm going to go to 4 times. And that's zoomed in on the complex that I'm currently reading. This is my OSCE video for CPR using an AED machine. My offsider has with her a suction unit and an oxygen bottle. I've got the first response kit and my radio. We're being called out to a unwitnessed collapse of a patient using Dr. ABC's assess the surroundings for danger. Do you see any danger?
No.
I don't. Alright, going ahead with the RFO response. Sir? Sir, can you hear me? Hello, it's St. John's Ambulance, sir. Sir? It's non-responsive to painful stimulation, checking the airway for blockages. I can't see any blockages. The tongue is out of the way. Checking for chest rise and breathing for approximately 10 seconds. Can't feel any chest rise, can't hear any breathing. Alright, can you begin compressions?
Sure.
I'll set the AED machine up. These AED machines are quite simple to use. They can be found in lots of locations, work environments, and the ASB Bank, I believe, carries them in all branches. Apply this to this side. Just randomly apply this to the other side. Okay, while this machine sets itself up, I'm going to call for backup. Control, this is AUT1.
AUT1, go ahead.
Confirmed R49, requesting R50. Don't touch the patient.
Backup is on the way. Copy that.
Shock advised.
Alright.
Charging.
Everyone clear?
Stay clear of patient. Deliver shock now. Press the orange button. Shock delivered.
Shock delivered. Alright, please continue.
Paused.
Yep.
Start CPR.
Alright, I will get a bag valve mask out so we can deliver some oxygen to this patient. Making sure that this is firmly attached. First, I'll put in an OPA of the correct size to make sure that the tongue stays out of the way of the patient's esophageal airway. Putting this in and scooping it around. Excellent. I'll now apply the bag valve mask, ensuring a correct seal using the Mohs mnemonic mentioned earlier in my video. Alright, could you count for me?
Yep. 25, 26, 27, 28, 29, 30.
Alright, 2 breaths. Continue. Not putting too much air so that you don't overextend the lungs.
12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Chest rise is good. The ratio for compressions to air ventilation should be 30 to 2. Good job.
25, 26, 27, 28, 29, 30.
Would you like me to count or are you good?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
2 breaths. Satisfactory chest rise.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Stop CPR.
Everyone clear away from the patient.
Analyzing heart rhythm.
Let's switch outside just in case you
Stay
require
clear of
compressions.
patient. Analyzing heart rhythm. No shock advised. Paused. If needed, start CPR.
Okay, cool. Twenty-six, 27, 28, 29, 30. This is my OSCE video for measuring vital signs, and I'm here with Nana today, who has agreed to be my awesome patient. So what I'm going to do today is I'm going to take your blood pressure, which I assume you've had done before.
Yes.
Yes. So it'll be a tight squeeze around your arm for a little bit, and I'm going to measure your pulse, and then I'm going to have a little listen to the top of your lungs on the front and the back.
Right.
If that works for you?
Yes.
Yeah. Okay, awesome. So yeah, Nana's blood pressure is quite low.
Yes.
You're currently at around 73 over 110. Would that be about right?
I don't know.
You don't know? All right. I'll take this off your arm for you.
He never tells me. All he says,
It's a bit low.
it's low today.
It's lower than mine.
No.
Ah. Alright, so what I'm going to do is I'm just going to have a feel for your radial pulse.
Yeah.
Yep. Cool. A good way to take a radial pulse is just to count it for 10 seconds and times it by 6 if you don't have time to count it for the whole minute. This way you can also count the patient's respiratory rate by counting how many breaths they take in the same amount of time, subtly, because you don't want them to notice that you're measuring how much they're breathing. Otherwise it might change the way they breathe. Suddenly become conscious and you're like, am I breathing right? Oh my god, I don't know. Okay. Cool, so you're about 18 breaths per minute, which is well within normal range.
Oh, good.
And your radial pulse is approximately 89,
Okay.
which is also very good.
Oh,
Yeah.
Yeah.
You're in pretty good health, I have to say, for a 90-year-old. Yeah, and you're putting me to shame. All right, so now what I'd like to do is a thing called oscillating, where I listen to the top of your lungs just to see how your breath sounds. All right, it's a little bit cold, but I'll just put the stethoscope here and just on the other side, so you can stay seated if you like. So we've just finished having a listen to Nana's lungs. They sound pretty good, good volume. There's a slight crackle when she exhales, but I understand that you've been sick lately. Is that right?
Yes.
You've had a bit of a cough?
Yes.
That accounts for that. Well, thank you for letting me take your vitals.
You're welcome, dear.
Awesome.